Well, welcome everyone to All Things Patellofemoral this evening. I'm your host, Michael McBrayer. I'm Senior Vice President at DJO, and very excited about this particular panel. Patellofemoral instabilities and those kinds of issues, we've gotten a lot of response from you all. I have a very exciting panel. I'd like to introduce that panel and then kind of give them an open question before we get into the program. So I'd like to introduce this evening Patella Doc himself, Dr. John Fulkerson. John, thank you for joining us.
Thanks for having
me. I'd like to introduce from the Cleveland Clinic, Latul Farrow.
Good evening, everyone. Thanks for having me.
And then from the West Coast, Stanford University. I don't know why I'm sounding like Jim Nance all of a sudden, but it's like Stanford University. We have Seth Sherman. Seth, thanks for joining us this evening.
Excited to be here. Thanks, Mike.
Before we get into the program, I thought it might be good for the audience to potentially understand the why of what you guys do within patellofemoral. We're going to get into the what and how. But the idea that all three of you are recognized for your work in patellofemoral issues, and it's a difficult diagnosis. It's obviously there's some difficult patients and the procedures are complex. So I have a lot of friends in sports medicine who actually shy away from patellofemoral issues. They don't necessarily like, trying to deal with this. So I guess we'll start with the godfather of patellofemoral issues, and Dr. Fulkerson, why don't you give us the why you're involved in patellofemoral issues?
Well, actually, in my case, back when I started around 1980, there was not much going on, and you'd literally go to the academy meeting, and patellofemoral was always the last section. Usually, half of the people attending were on their way to the airport, and there'd be a few people huddled up in front. And, there just wasn't that much interest, and the topic seemed interesting. So I jumped into it with both feet and have had a lot of fun with it, to be honest.
So Latul, for you guys, I should call you, I know these guys personally pretty well. So if I use their first name, I potentially apologize. Dr. Farrow. For you guys that don't know him, this is a big man. He is physically a big individual. So, Dr. Farrow, how, some of these procedures in these, patients are petite. What led you to get involved in patellofemoral issues?
Besides the obvious question that there's not as much competition, because when you show up to a place and you say you're the patellofemoral guy, people get out the way and they send you patients. But, for all the things that I do shoulder and knee surgery, mostly knee surgery. I think you have that ability to have the biggest impact. A lot of these patients, they come in, they're either having significant pain and they live like that for much of their lives. And these patients are some of the happiest because they go from, very low when you operate on them. And then, once they recover, they're very high. And these are patients that sometimes, roll out of bed and their patella pops out of place. And so when you can fix these people, they're really happy. And so, very rare that you have a patient come back, especially with patellofemoral instability, and they're not happy with the surgery that they had done. So it's pretty rewarding.
Yeah, that's great. Dr. Sherman, you come from an orthopedic family. Your father, orthopedic surgeon in New York. Didn't he warn you about this? Didn't he say not to get involved in this patellofemoral issue?
He told me early on in residency, and maybe even earlier, you know how you treat patellofemoral patients, and then I paused and he says, you send them to someone else. So that was deeply ingrained in my heritage. And I think probably as the son, going the opposite direction of the father, he has a deep dive in everything ACL and, obviously knee, and still actually has a love of patellofemoral, but I've really, tried to take this kind of, to the next level with mentors such as John. I would just say briefly why I got into it. I didn't come out of residency wanting to do patellofemoral necessarily, or frankly, even my fellowship, but through mentorship. Jack Farr, part of the cartilage crew, and that's why I went to Rush initially. to do that. And then I begged John to help with an ANA course, and he's like, and I showed up on time or early and stayed late and gave it my all, and then met all of his his friends. And from there, learned about the Patellofemoral Study Group. And, I think just this group is just very special, that these are complex problems in their infancy, and we need to, work together to solve them. And I think John's going to outline nicely in a minute here the evolution. And now there's more groupthink, and we actually can do what Latul said and figure this out to some extent and really help people where, even today in my clinic, this is my last point, that a patient comes in and their doctor, their sports doctor, is very nicely trained, had never seen the condition or just said this is so rare. And frankly, now that we recognize dysplasia and rotation and all these synthesized issues with the kneecap, we can help these people. And I tell them, I see this unfortunately every week, and we're going to try to work a plan and make your life better. And that's really special.
Yeah, thank you, all three of you, because it's I think it's important to this audience, certainly the fellows that are out there, and taking good care of patients, will send your career on its way. So, for all of those on the line, if you need have a question, put it in the Q&A section. Dr. Fulkerson is going to be moderating the session. But throw those questions out there, and we can try to get to those answers. I'm going to hand it over to Dr. Fulkerson, giving us a little bit of the history and kind of laying the groundwork before we get into some case studies. So, Dr. Fulkerson.
All righty. Let's see. I'll share my screen. Okay. Here we go. Well stated by my fellow faculty. I think we have a not so well kept secret that the patellofemoral joint is actually a really great place to be. It's just a matter of learning how to do this type of surgery and learning it well, because people are very happy. So Seth asked that I go back a little bit and look at the history, and it was interesting for me to do this, actually, having been doing this a long time. Back in 1980, if you see this picture on your left, this is what was done for patellar instability. Basically make an incision like a total joint incision and advance the entire medial capsule all the way over, tighten the heck out of that joint so it could never dislocate again, and sew it all up. And in kids, we'd take a tendon and put it through the patella, and they call it the Galeazzi procedure. And if things didn't work out too well, there were no patellofemoral replacements. So back in those days, believe it or not, people used to take out the kneecap. That was a bailout. And then tibial tubercle transfers were done. Dr. McKay was doing an anterior transfer, which unfortunately did lead to problems. And these are all well published with skin problems, compartment problems, and so on. So people became very scared of anteriorizing because often it was done too much. But the medial tubercle transfer that's still done today, the Elmsley Trelot procedure, was being done, and it is still done today. And then I came along in my career, and I trained with Dr. Southwick, who described the biplane osteotomy of the hip. And it occurred to me people were moving the hip in two planes for slip capitofemoral epiphysis. And so I said, well, we should be able to do that in the knee, and people are moving it medially and lateral and anteriorly. Why don't we design an osteotomy to do both? And fortunately, I was at UConn Med School, and I was able to try this out in cadavers, and it worked, and has helped me to get my career going because people seem to like that operation. Then back in 1990, I came out with this book, and at that time, Elira Gomez in Brazil was doing MPFL reconstructions. They were not being done in this country, but Don Fithian came along and popularized that technique in the late 90s, early 2000s. And some of the other highlights, just to go very briefly, Henry de Jure gave us a classification for trochlear dysplasia, which was popularized later by his son. And then Bob Taiji emphasized hip rotation and the importance of the overall lower extremity and patellar instability, which was a whole new concept. David Jure developed the trochleoplasty concept based on the classification that his father developed. And unfortunately, that was shown later by Rouenet to have a fairly high level of osteoarthritis, 15-year minimum follow-up. So there's evidence of MPFL reconstruction and tibial tubercle osteotomy efficacy in patella instability management. At the present time, we know that that works. So just to start off with acute dislocation, one slide here. We'll have a case presentation on this later. This has changed also. We're up to the present day now. In 2019, Dr. Havezi came out with his group, basically showed that these 4 factors are very predictive of recurrent instability after acute dislocation. Young patients, trochlear dysplasia, a high disparity between the tibial tuberosity and the trochlear groove, and skeletal immaturity. If you've got all 4 of those, there's a real good chance that patella is going to dislocate again. So the classic teaching for boards is non-operative treatment for the first-time dislocator, but that's not necessarily always true now. We're getting a little better at understanding who should have surgery. DJ Ortho has been important in developing treatments for non-operative management, including the true pull brace. I actually got involved with that with them. But I would really credit Scott Dye for his strong influence on the importance of exhaustive non-operative treatment. So that's classic thinking, but it's still true to this day. We really need to exhaust it. And part of that we've learned in the last 10 years in particular is the importance of core stability. And I credit Bob Taiji with really emphasizing that. That's a really important component of non-operative, starting at the hip, to make sure you have a core stability in these patella instability patients. So I was asked to talk about what I've learned and how I've processed all this, and so I'll try to give that to you in a nutshell quickly here. Basically, before doing any stabilization for recurrent patella instability, I would recommend that you make sure your extensor mechanism is balanced, both by non-operative and surgical means. Tibial tubercle transfer is a classic way to get the patella in the right relationship with the trochlea. You can do it by rotating the femur or the hip, but I think this makes the most sense when you need to compensate sometimes to get the patella lined up. And you want to do that before you do any tendon graft stabilization. We think in terms of medializing, when you just want to line the patella up. If you need to unload an articular lesion on the distal or lateral patella, then I like to recommend an anteromedial tibial tubercle transfer, which is more forgiving. But this is a landmark paper in my mind. And again, I'm just giving my spin on all these things. Liu and Schubenstein in 2018 came up with this study, 121 MPFL reconstructions, regardless of the amount of trochlear dysplasia. That's what's so landmark about this. They got 94% return to sports in 1 year and very high level of success in stabilizing these knees. These were knees that did not need to have a tubercle transfer, which is important to recognize. So this was selected for people who did not need an alignment procedure. So the moral of the story is make sure you get the alignment right, do a tubercle transfer when you need to. If you don't need to, you don't need to, and you can just stabilize. But this left me with the feeling of why would we do a trochleoplasty? And these have become a bit more popular, and there is some role for it, but I don't think it's very big. And we've been looking at 3D models of this. And basically, when you change that slope, and I like to think of this contour here is a very delicate balance mechanism. Yes, it's very curvilinear. It's not normal. It's dysplastic, but it is congruous. And when we change that articular surface, we're doing something pretty profound to these people. So I think what we need to do is understand trochlear dysplasia better, because you will change the way that tracks, and it's not going to be congruous after you do a trochleoplasty. So this is basically how I like to do the tubercle transfer. Just one slide here just to show the oblique osteotomy, and then you just slide this over tapered anteriorly at the distal aspect, and then 2 screws to hold that securely. Pretty routine operation in my practice. Anterior medialization tubercle transfer reduces risk of post-op increase of patellofemoral contact pressure versus medialization alone. And that's in a nutshell why we do this anteriorization as well. And Seth, who is part of our faculty here today, Seth Sherman, pointed out that tubercle transfer to balance alignment adds no risk to medial reconstruction in patella instability. So between that and the fact that we can assure better balance and less likelihood of recurrence and problems, it's very important to get the alignment right before you do stabilization. That's probably my main message. Now here's a 29-year follow-up. Anterior medialization on one knee and not on the other. And this is probably my favorite slide because it shows that the one that had the anterior medialization was preserved after 29 years. The other side, somehow this person never got that side done. They tracked laterally, chronically, excessive focal loading, and the joint just broke down. So this is pretty dramatic evidence that these tubercle transfers have long-term benefit. Remember the anatomy. I don't want to spend time on this. We want to get to the cases, but it's complicated. Look at this closely, study it. If you're going to do patellofemoral surgery, learn this. There's a lot out there in the literature. Smigilski did this incredible dissection of the it's a medial patellofemoral complex. It's not just one cord that goes from the femur to the patella. If you want to be a patellofemoral surgeon, you've got to know every component of this. And that will make you a much better patella stabilization surgery because you'll be able to get to that point right at the distal aspect of the adductor tubercle every time on anatomic basis. I think there's a paper that just came out, I think it's AJSM just this month or so, that showed that the radiographic landmarks are not as accurate as we had hoped. So they're good to use if you want to get in the area, but know the anatomy and just go right to that. Here's the adductor tendon, adductor magnus, right into the adductor tubercle, and then just put your graft right at that distal end of that, bring it up under the VMO. You can see where the blue dot is. That's the drill hole, distal end of the adductor tubercle. Graft comes up under the medialis. Fix it on the femoral side. This is what I like to do. There are different ways to fix it. You can fix it to the patella. I bring it up under the VMO, and then I wind it around through the distal quad tendon, just like this, put a hemostat in, and just wrap it around and suture it down. Just cycle the knee as many times as you need to. Make sure that it's not too tight. And that's a hedge against patella fracture, which is very uncommon, but it does occur. And always allow one quadrantal lateral translation. Don't ever make these too tight because those are unhappy patients, which as patellofemoral surgeons, we do see from time to time. Perfectly done surgery, except made too tight, the patient's not happy. And here again, credit our sponsors for this evening with their products. ICE in the short-term rehabilitation. Afterwards, I like to use a splint for 10 days, then a long leg brace, gradually open it up to 90 degrees over the first 4 weeks. Partial weight bearing after an osteotomy, full weight bearing if it's just a medial reconstruction. And then right into physical therapy at 5 to 6 weeks, light running usually 3 to 4 months, full sports 6 months after an MQTFL, and we like to wait longer after a tubercle transfer. And stay tuned for Patellofemoral Foundation course, which is really almost ready to go online. If you check this website, you'll see that becoming available. Very intensive course on the patellofemoral joint. So with that, I'll stop sharing my screen and we will go right to Seth, who has a great case for us.
All right. Can you hear me, John?
I can.
And can you see my screen?
Yes, I can.
Excellent. So that was an outstanding overview. I'd never, Latul and I were chatting how we had not heard how Fulkerson came up with the Fulkerson. So just amazing and really inspirational to us young surgeons. I feel so inadequate now.
No.
I better get to the lab, you know? So there's no tricks in this case, and we'll go through and hear Dr. Fulkerson and Farrow's thoughts. So this is a 14-year-old. He's a basketball athlete. He had a non-contact first-time patella dislocation event in February of 2019. It was closed reduced, no prior history on his opposite knee, which was perfectly normal. He's skeletally immature, as we would expect. When we look at his lateral, he has no patella height abnormalities. He does have trochlear dysplasia, so I'd encourage the fellows, get good at scrutinizing your lateral. It is the key to the patellofemoral joint. So you can see and learn about crossing sign, learn about trochlear spurs, learn about double contours, learn about patella height and engagement. It's critical. But this one, there is some dysplasia, but no height abnormalities and no obvious fractures or loose bodies. So Latul, just throwing it out to you. This kid comes in at that time, first-time dislocator, no obvious things on x-ray. Do you want more information? Any other imaging routinely in your practice? I think you're on mute, buddy. He's also
So yeah, so this athlete, non-contact mechanism, open growth plates, no major anatomic things to look at here. Yeah, I think this is a patient that certainly you can. Yeah, you did. I don't know if you mentioned like J tracking, so no J tracking.
I actually hadn't seen him at that initial presentation.
Okay.
I don't know.
Yeah, so that's the only information I think I'd want to know about this athlete. Yeah, obviously growth potential remaining, things like that, but certainly someone who I could consider treating non-operatively with that story,
Okay.
without a J sign.
Yep. John, are you getting an MRI here, or any other information you need or want?
Well, interestingly, we're really into 3D imaging now. We would actually at our place get 3D CT.
Okay, so you get a 3D CT off the bat, and no MRI. You think that you can get all the information you need about the soft tissue structures with the CT?
Well, you would see the bone fragment if there is one, but we like to have an MRI also. So I mean that's the whole. I mean that's what we really like to have is both.
Hey guys, this is Michael. I'm curious in the CT scan versus MRI. In reference to that, what is there a cost difference? I mean, is there any significant difference between the two?
CT is typically a little cheaper. There's more radiation involved with it, but the amount of information that you can get on the bony morphology of the trochlea is just spectacular, and any damage to patella. So so you can spin it around. Really, it's for me, it's very powerful to look at that 3D CT. I honestly would rather have one than an MRI, but the MRI has obvious advantages. And really, the whole thing is have both.
Just to add to that point briefly, we're also trying to work on, and I know Adam Yankee at other centers, perhaps others, on MRI 3Ds, also giving us information like John gets from his CT, also getting hip version, torsion. Point being, we need to understand all these complex variables in and out of the joint. So just to make a point for the fellows, cartilage damage after dislocation is very common. Less than 35% is seen on plain x-rays. And so in my practice at this point, I really am getting an MRI or some advanced imaging study for all first-time dislocators. We want to rule out the osteochondral injury, which is still our real indication for surgery here, but also for risk stratification. So if they don't have that loose body, I can look at those risk factors and kind of tell them, whether they have a high or a low risk of dislocation. And John alluded to that in his talk. So here's the MRI that was obtained by the outside physician. You can see there's no fractures or loose bodies. The TTTG is 12. The patella trochlea index is normal. There is trochlear dysplasia present. And so I guess, Latul, let's go back to you. So for this kid, you're treating them non-operatively. Maybe get some specifics. Are you sleeve, brace? How do you progress them? What do you tell them, taking back?
say if this is acute, and if I think when patients present to the ED, initially those patients end up showing up in the office in a neomobilizer. I try to get them out of that ASAP. I think it's great first couple days to a week just for pain. There's a lot of people who will talk about sort of range of motion bracing. One of my partners, who I respect tremendously, and the big reason why I went into this thing, Jack Andrish, he likes to put these patients in a range of motion brace locked at 30 degrees. I am not a fan of that. And, you know, where I've gone with my evolution now is once I get them out of the knee immobilizer, they go straight into a patellofemoral stabilizing brace. And so I like the J brace. I like the True Pull Light. I used to do the J brace, years ago, and I think patients like the True Pull Light much better, especially my athletes. And so that's what they go into. We start getting them into physical therapy right away. I want them to move. And I just don't buy into the idea that, you know, putting them in 30 degrees, sort of reduces the patella unless the MPFL heal. Yeah, they would have to be in the cast or in it 100% of the time for that to actually work, I think. And so as soon as they come out the shower and stuff like that, I don't think it matters. And so, so that's not the way I approach that. And in terms of counseling these patients, this patient, you know, when you sort of risk stratify, I think they're pretty low on the risk stratification in terms of risk of recurrence. And I tell them, and that's how we talk about operative versus non-operative management.
Right. Low TTTG. He is young. He's got a little bit of trochlear dysplasia. So let's just say, for the sake of discussion, let's say that he had a convex trochlea. You know, you take a look at the X-ray, and he's got a convex trochlea. And he doesn't have a loose body, but he's really convex. I guess what I'm getting at, is there a point, what are the criteria that either of you would say that might make you look at it differently, that you start thinking about doing an acute surgery? Or maybe not acute, let's say.
That's actually a great point. And in the interest of time, let me just do 2 more slides and we're coming right to that point. Here's our kid. So this is using the meta-analysis, from last year or this year. So he has, all these kind of risk factors, his age, open physis, shallow trochlea. If we look at, we're looking at a 70 to 74.8% chance of recurrence here for this kid. If we go by the data, here's what John showed, the RIP score. He has 65%, recurrent instability at 5 years and 80 at 10 years. And so, we'll kind of come back to those thoughts. One thing, just to answer John's question, to my knowledge, trochlear dysplasia and a lot of these were lumped together, right? If there's any dysplasia, and that's not the way trochlear dysplasia functions. It's not, it's not just a little bit or, shallow, flat, convex. You need to really stratify it better. So I think we have work to do there. I probably use the information here, but I also do what Latul said as far as once you do a little rehab and see them back, do they have a jumping J sign perhaps? Do they have apprehension into deep reflection? Did their other side ever have issues? And, start to, really lay out a relative argument for early soft tissue stabilization. Any thoughts on this, Latul? So, I laid out the risk factors for this kid in particular. Are you treating him non-op with a 70+% chance based on our information?
So I'm used to seeing some pretty bad dysplasia, and so my spectacles when looking at that, I say yes, that is some dysplasia, but I like the way you just sort of explained it, that there's really no, it's a continuum. And so when I look at that dysplasia, I say, well, that's not that bad. It's not a convex, situation, not a J sign, and so. For me, I bumped them down into a little bit less risk, with that because of that. But I think that doesn't necessarily change the way that I counsel that patient in the absence of a true J sign.
So raise your hand if you would operate on him at this point. So I think that's still kind of, where we are, right? And so he was treated non-operatively. He had physical therapy. He gradually returned. They didn't critically do any return to sport testing for, the dynamic valgus that John showed in his picture or any of the other single limb balance issues. He felt 80% of normal. He went back to basketball and boom, second non-contact dislocation 6 months after the initial event. Now he comes to a different doc. He comes to me. He has difficulty weight bearing, a large hemarthrosis, and limited range of motion. Here we can see his x-rays. In the interest of time, we can see the large bony fragment. So same kid now with significant injury. We have osteochondral injury to the patella, as you see there. We have lateral femoral condyle, kind of shear injury from the dislocation. With a loose body, you can see posteriorly. And so here's kind of, because of the loose pieces, we scope them. This is the lateral femoral condyle. So that's pretty small, 6 millimeters. And you can see that little wispy fragment. It was not good tissue quality, the one that was fished out from posterior lateral. But here's the patella, a big cartilage, mostly cartilage, minimal bone, but involving a good amount of the weight-bearing surface there. And so here's kind of the summary of those findings. Maybe, Latul, do you want to kind of go down the list and tell me, if, you're in the scope now, what are you going to do for those 3 things?
So I think you hit the nail on the head. The lateral femoral condyle lesion is pretty small. Certainly I don't worry as much about that. I'm not a big microfracture person. The cartilage only loose body, minimal bone. We see these all the time. That's a very characteristic location. So distal portion of the medial facet and kind of the coup contra coup injury when it dislocates. And those, you cannot get a screw in. You can't really use chondro darts and things like that in there. So, beauty of being in this sort of patellofemoral study group, you get to see some good novel stuff that's done. And these are injuries that I've had some great luck, going in and doing a transosseous sort of suture technique to fix these pieces. Because usually if these pieces fit, they're acute. You can basically use a suture technique. And so I just drill right through the patella, put suture through like a PDS suture and just tie that down. We get excellent compression, and those heal fairly well. And it's important because these are almost kind of like the engaging Hill-Sachs lesions. So I think fixing those are important to kind of restore bony stability to the patella. And then I think if you're going through the trouble and you're there and you're fixing the cartilage, you got to stabilize the patella. So soft tissue stabilization procedures for that.
John, may I ask you, in your experience, I know a lot of my colleagues and young people worry if we're going to fix these things and stabilize that they might get stiff. Do you advocate for Latul's strategy, which would be the strategy that I do and advocate for as well?
Yeah, no, I agree with that. I just wanted to add too that, I think it's interesting, some of these fragments have just a little bit of bone on them. And that's always a question in my mind. You have like probably 4 times as much, and you've got this little piece of bone. Let's bring this up because I think I'll actually suture the cartilage back. If it's got some bone, maybe there's something that maybe, and I've had that be, usually it's not completely successful, but at least you get some healing, and maybe you have to go back but I just think that's an important concept. If there's some bone, you may want to give it a shot. I don't know. What do you guys think about that?
Yeah, so I'll show you what I did, and then we can wrap the case up. But, basically the scope part, we remove the loose bodies carefully, inspect both of them. The lateral femoral condyle, for all the reasons that Latul said, I just leave it alone. I don't think that's going to be a major issue. It's quite small, and I couldn't have fixed that anyway, and I don't microfracture very often either. The patella piece we carefully removed. It didn't have a lot of bone. He is skeletally immature. Just a point, I do take a Macy biopsy, so I want an ace in the hole because I can always grow cartilage and do something later. That doesn't mean I'm going to do a Macy, but I like to know that I have that. This kid's young and there's a lot of life left. And then I approach this open. You can see it's a pretty big area, and prepare the defect bed with healthy bone. For me, I've started to use kind of a knotless suture anchor in the center of these cartilage-only defects. I can actually weave it through the fragment, so I can get kind of like a manhole cover compression. 605 lacy on the edges, fibrin glue if I so choose. And that's worked for me in cases like this, where we can get a really nice stable fixation for early range of motion. And then I add a physial sparing MPFL with a Gracili's allograft was my choice for this case. So, I think he's 6 months now. He's doing well, slow and steady. He's walking normally. He has no fusion apprehension or guarding. He's starting a run progression, so this is not quick. This is slow. And functional score is about 75%. So, he'll get there, I think, but, we're not rushing forward. I don't want to move into salvage mode with having to grow cartilage, transplant cartilage, unload with realignments, etc. I want to keep him right where he is. And so that's kind of, what I have for that case. Any final thoughts or words, Latul, for this one?
No, this is the approach that I take, and yeah, I fixed a lot. I fixed a lot of these lesions over the years, and essentially very similar, like cardiform, for chondral defects, and I have yet to have to go back in to debride cartilage or remove cartilage. Even I think there's always a calcified cartilage layer along with a very small piece of bone underneath that I think will get these to adhere. So I think that looks fantastic.
Yep. And, there is some literature to support this, that cartilage-only fixation can work, particularly in these skeletally immature athletes. So I'd encourage you to read this and other papers on the topic. This is what John was talking about, the Patellofemoral online course. So we're so excited to all be involved in this in one way, shape, or form. I think it's going to transform education, and it's coming soon. So really look up for it. Certainly, hopefully the majority of this will be out in full force by the annual meeting. And thanks to Mike, Melanie, DJO for having me. It's really a pleasure, and this is just so much fun to really tackle these challenging issues with my friends and mentors. So I'm going to turn it to Latul, and we'll go to recurrent instability, I think.
All right. Let's get my screen up there. We'll go to case 1. Thanks, Seth. That was a great talk. Everyone see my screen's up? Yes. And so nothing to disclose. So this is the first case, 20-year-old female, so right knee instability. She has a history of left knee instability also, and had a Fulkerson and lateral release done, and she had previous history of bilateral dislocation since she was 7 years old. The Fulkerson side had a very painful recovery, but she was okay now. Was coming to me with complaints of right knee instability, and she had been seen by another surgeon in town who had done the osteotomy for her. And because of her rough time that she had with that, she was coming for another opinion with respect to her new knee. So these are her stats. So she has a suprapatellar spur. She's got a crossing sign here. Her CEI, Caton-Deschamps index is 1.2, so not extremely high, and de jure B. And then this is her dynamic CT. She has increased tilt, sulcus angle. She has the negative congruence angle, obviously, and then lateral translation of her patella. And this is her TTTG distance, which is only 14 millimeters. And so this is something that I don't even blink at. Her alignment's really good. And this is something that, in my opinion, was not indicated for a osteotomy to start with. And so these are, sorry about the sound here, but this is her in the operating room. And this is her osteotomy site. We were going to take out her screws because they were still kind of irritating. So you can see that she still has instability of her patella despite her TTO that she had done. And so we were there to operate on her, mainly operate on her right side, which also has the same instability. So what was our plan? So we talked about right knee arthroscopy. She had some chondrosis, so we did a chondroplasty. And I'm a big proponent of addressing the lateral side with many of these patients, especially the patient who's sort of the long-term patellofemoral dislocator. And so we did a lengthening for her. I very rarely will do a lateral release, and that's almost reserved only for the patient who's like a congenital dislocator who comes in, they've been chronically and dislocated since birth. And then we did an MPFL reconstruction, for her. So this is her knee afterwards. So this is her Fulkerson side here, her TTO side. So she still has kind of an L sign or J sign. She's still jumping out there. And then the side that we did her MPFL on here, she tracks fairly normally. Certainly had a great recovery with respect to that, and she's done, really well with this. So, when you talk about MPFL reconstruction, and I do TTOs. I have a very complex patellofemoral practice, so I do TTOs. But certainly, I think for the vast majority of the patients that I see, you talk about operative management with soft tissue techniques. And as we can see over the years, the results with these are pretty good in terms of rates of recurrence and complications. And so it's really something that can really be your go-to in a lot of your patients. There's been some great studies, some of these that have been quoted, looking at isolated MPFL. So in patients with a high TTTG, greater than 20 millimeters versus lower TTTG, high-grade dysplasia versus low-grade dysplasia, patella alta versus non-patella alta, increased femoral aneversion. And the study from joint knee surgery, really no difference between the patients with respect to anatomic parameters with MPFL reconstruction. So, so even with a lot of risk factors, they still did well. And this is the study from Beth Schubenstein that Dr. Fulkerson, as well as Seth also mentioned. Again, patients with high anatomic parameters and risk factors, they typically will do very well. They had 1 in 72 patients with redislocations, and all had improved outcome scores. But one of the caveats to this study is short-term follow-up. So we don't necessarily know, and I think Beth is going to be publishing on her longer-term follow-up for these patients eventually. But, it's one of those things where you don't know if this is something that's going to stretch out over time, which certainly can happen. But in our hands, for the most part, this has been a good way to approach many of these patients. But again, with very high parameters, I think you have to consider some other options for these patients. And this is looking at a patient. So this is looking at a study from Larry Heimstrup in Canada. Again, looking at some of the high grade parameters with respect to our populations. And again, they had a group of very high grade dysplasia, in a large part of the group, high TTTG, some patella alta. And all these patients did better and did great with MPFL reconstruction, even with these elevated parameters. One thing I'd like to point out, the one area that I do think is a big negative risk factor for outcomes is age. And so some of my patients who are older, who just have soft tissue procedures, I do see that they do a little bit less well than some of my younger patients. And so I in my practice, in some of those patients, if they have a hint of rotatory problems, I will be, I am more likely to add a TTO in that population. For whatever reason, I think they do a little bit better along with their soft tissue surgeries. And then looking at patients, because the question is, well, if you have a patient with Ehlers-Danlos or Marfan's disease or something, what are the outcomes in those patients? So even with the increased Biden score, she found that the results are pretty good, with just soft tissue reconstruction, and patients did really well. This is a study, sort of a small cohort of failures after MPFL reconstruction. And, the good thing is you're not going to find some big studies with large amounts of failure. So even though this had 10 subjects, it's probably one of the largest studies that you're going to see with MPFL failure. And they found that the big risk factors were increased Catan de Chance, so odds ratio of 4.9, so in a patient with patella alta, and a pre-op J sign. And obviously those things are probably intermixed. And so patients with high CDI are probably more likely to have a J sign, as that may be part of that pathology. And so those are things that you really want to consider pre-op so that you don't necessarily get a failure with these patients. So, my take-homes for this is that isolated MPFL reconstruction can be a good strategy for most patients. TTO is not needed in, what I would say, the majority of patients with patellofemoral instability. And I don't release a lot of retinaculum, but I will do a lot of retinacular lengthening on many of my patients because iatrogenic medial instability is a real thing. And then, certainly we can open up the floor for questions, but that's sort of my approach when looking at the recurrent dislocator. And that's usually a little bit more cut and dry because those patients come with a lot of disability, and those are the patients that you can really, truly help out, with your surgery. It's not necessarily a question of should you or should you not. It's really a question of, what exactly needs to be done for these patients.
That's great. Great talk. So I guess I would ask you, Latul, and I agree with you. In concept, I really agree. I do far more MQTFLs alone without a tubercle transfer than I do with a tubercle transfer. But I guess, and you mentioned the 2 points, the increased Caton de Champ and the J sign. What are you, do you ever do a tubercle transfer for lateral tracking in a recurrent dislocator, or is it only for an elevated Caton de Champ and J sign?
So for sure. So I calculate, all these things that in our risk calculator, I calculate those on every single patient. So, my threshold for adding a TTO, is a little bit higher. So I don't necessarily use sort of 20 as a TTTG as my cutoff. I started looking at patients who are more like, 23, 24 millimeters on a true dynamic CT before we start to add, bony procedures. But yes, I do. And I would say, looking back at my numbers recently, I probably add a TTO to probably about 20% of my patients, to be honest. So definitely, I don't want that to be my message that it's something that I never do. We still find that there's patients who need to have the rotation addressed without a doubt.
And Seth, how do you look at it? You've been one who proponent for doing TTOs. What are your criteria? What percentage would you say of your instability patients end up with a TTO?
Again, probably the majority of my TTOs, for instability or not, are to unload chondrosis. So I think that's a different discussion. This patient has no chondrosis, so higher in that group. And those are some of the ones that were excluded from Beth's study, right? I kind of take this clinical. I think that if they have a jumping J sign, that the med student can see, and apprehension into deeper flexion, and then if they have the issues on the opposite side as well, and they're young, and they have even subcritical values of a lot of the risk factors, I start worrying about whether or not an MPFL alone, with or without a lateral retinaculum, is going to suffice. That doesn't mean I'm pulling the trigger on the bony procedure, but I'm certainly thinking about it much more. I wonder, Latul, did this patient have a true jumping J sign, and did they only have apprehension at 0 and 30? Because to me, that'll push me in a different direction. I'll stop there first.
So this is early career for me with this patient, and this was back in the day when I was not doing any kind of trochleoplasty at that time. I was very rarely using like patellar tendon shortening, and again, I think with her tubercle not necessarily being that lateral, she was not necessarily a candidate for TTO. So I do think some patients you kind of get away with things, and we've got long-term follow-up for her, and she's still doing very well with both knees. And so it may be something I think about a little bit differently now, because I think when you see those patients with a J sign, so you got to do something, I think, for that. So, I'm not doing a whole lot of primary trochleoplasties for those patients unless it's really like convex. But I think in that situation with her TTTG being a little bit on the higher side, I think at some point you sort of, you talk about adding something, whether, you're doing a patellar tendon shortening, or you're doing a small sort of Elmsley tree-out with some distalization. And so I think that's the way you kind of address that, because I do think that suprapatellar spur and patella alta are both contributors to the J sign.
Well said. I might editorialize a little bit and just say that with our 3D modeling, one of the things we're seeing is that the concept of moving tubercle instability, we think maybe is more a matter of accelerating the patella into the trochlea a little sooner, which certainly goes along with distalization. and also with medialization. We get it into the trochlea a little bit sooner. That seems to be really more what it's all about. But I think what's most interesting, I think, for those of you listening, I think basically we're all on the same page. You know, maybe Latul's doing 20%. Mine is about 40%, I think, but I also get people sent to me that need tubercle transfers. So more people typically with recurrent instability will end up with isolated MPFL, or in my case, QTFL reconstruction. So any other comments? Seth,
to make it, yeah, go ahead, Jim. Sorry.
No, go ahead. I'm just turning it to you.
Oh, to make it crystal clear from my practice, you know, if they have that clinical exam findings and a Catan de Champ 1.4 or above, I'm doing distalization for instability and really reserving anteriorizations for cartilage unloading and most of the time medializations for cartilage unloading. So anteromedialization combination procedures.
Hey guys. This is Michael. There is a comment in the chat section you guys may want to take a look at. Just to
yes, I was getting there. So I'd like to acknowledge my good friend Lori Heinstra, whose studies I hope I quoted correctly. So she said, great job, team. All my instability gets an MPFL, TTO, or trochleoplasty or other things added when needed. So currently about 75% isolated MPFL with or without lateral retinacular lengthening, and 10 to 20 with TTO. So, you know, Lori's obviously, she's a juggernaut in the sports world, especially patellofemoral world, and one of my favorite people in the patellofemoral study group. So thanks for your comment, Lori.
Yeah, thank you, Lori. Saw Lori's name on the list, so thanks for joining us. It's just interesting, 75% isolated MPFL. And I'm saying 60%, Latul's saying 80%. Seth, you're probably somewhere in that same range.
I think I'm right in that ballpark, yep.
So I think, you know, we're not talking big differences in numbers there. We're all kind of in that. So if you're doing more than 50% TTOs with your instability, you're probably doing too many.
And this is the thing that I love about patellofemoral surgery. It's not like a one-size-fits-all approach to your patients. And, you know, I like to think about these patients. You know, I'm like crunching numbers. You know, I'm drawing pictures and stuff for the fellows and residents. This is what I love about it. You know, every patient is kind of different. You dial different things in to try to get the best results.
Atul, in that young patient, bilateral, you know, likely some underlying risk factors, of course. I'm more apt to throw the relative kitchen sink on that person and realign them and stabilize the soft tissue. Whereas it's interesting when I have a 35, 40-year-old, some early chondrosis, same risk factors, but still unstable. Maybe I'm trying to hedge bet and just do the least possible because I worry about the morbidity of the combined procedure. Now, maybe I'm wrong because that's the patient that doesn't do as well, you said. You know, it's interesting.
So, and by not doing this well, so I do hedge a little bit on those patients, meaning that I don't necessarily go in and throw a big graft in those patients, you know, do, you know, autograft or allograft, semi-T or anything. So those patients are more likely to kind of do like just an imbrication or a reefing on the medial side. And I think, you know, doing, you know, a TTO, and I think they do pretty well with the TTO in that approach. And I don't necessarily think they need as much. And there are some studies to suggest, so the patients who have a very high, you know, TTTG, that if you ignore that and just do an MPFL, even though they do well, they may not read us okay. There's some studies that show that some of their patient-reported outcome scores are a little bit less than the patients who had combined TTO as well as soft tissue procedures. And so I think I pay a little bit more attention to that.
Remember that slide I showed too, because that's a real case. And the fact is, if you leave a patella, and this is what we don't know, even with some that we just do an MPFL, down the road, if the focal loading on the lateral side is constantly high because it's tracking laterally, you can make them stable with a medial reconstruction, but they're going to wear down and be set up for problems later in life. So you do people a favor if they are tracking laterally to get them stabilized at the same time. And plus, you're going to cut down the risk of a recurrence. But still, that's a small, relatively small number overall.
And Latul, the opposite side of your patient, you know, is just a great example. You know, they had a realignment, you know, and that was bony, but no one paid attention to the soft tissue balance, and they were clearly still unstable. So they didn't treat the essential lesion. who knows if a well-done TTO, you know, for borderline alta and borderline lateralization with that MPFL, they'd be even doing way better, you know, and have less risk of stretching out than maybe your right-sided MPFL. So I think there's more questions than answers, but I don't think we can throw the TTO baby out with the bathwater on that left side because they didn't, you know, go through the problem list.
Oh yeah, absolutely, absolutely.
I think you guys would agree too that doing an MPFL properly it's a great operation. It's got to be done correctly, not too tight. It's got to be anatomic, but it's a great operation. It's home run surgery, but you got to do it right. And therefore, for us these days, I think putting that graft in there, I mean, I shouldn't take it lightly, but we don't see it as that big of a deal. You know, you put a good graft in there, you're buying that person assurance. We have a little bit of time left. I guess at this point, let me see. Oh, I do have another comment here. I think this is from Lori. The more risk factors, the more likely I am to add procedures. I think people sometimes forget generalized ligamentous laxity. It is a big risk factor for failure. Don't worry, paper to show that it isn't rude. All right, well, thank you, Lori.
Can I ask one more question to Latul and John before we close? What do you think about the concept of subcritical values and whether they're additive or exponential? Meaning, if we look at the shoulder, subcritical bone loss is a huge issue on the glenoid and Hill-Sachs side. And, you know, we shouldn't just say there's a threshold, let's stay below it. We need to be more thoughtful. And I think we need algorithms and machine learning. You know, I think we need next level things to get there together.
So,
Yeah. Oh, go ahead, John.
well, no, I'm just wondering if you could explain a little more what you mean by subcritical values.
I mean, if you have low-grade Catan de Champ that you're not going to act on, 1.2, you have a TTTG that's 8, a TTPCL that's 22, you have borderline antiversion and a shallow trochlea. You know, take those 5 things and put them in your, you know, area and pressure, you know, maps and put them in a patient database and see who does well with what. You know, it's just fascinating.
Yeah. Well, you probably give us the answer in a few years, right, Seth?
We're getting there, but I don't have it right now. I call Laurie.
Well, those are all good questions. I mean, I think we're learning, you know, there's so much more energy going into patellofemoral these days for, you know, fellows out there attending the course. I encourage you to really take our course, the Patellofemoral Foundation course. I mean, I think you'll see this is, you know, it's probably, I'm going to say 10 hours worth of material. You know, there's a lot to know, and it's absolutely fascinating. It's a great field. You can really do a lot of good things for these patients. We're still answering these questions, but we're a heck of a lot better off than we were 10 and certainly 20 years ago.
And just real quick, Dr. Fulkerson, that picture that you showed with the TTO, post-TTO on one knee and then one knee that didn't have the TTO in the back patellofemoral OA, I think all of us have seen that. One of Jack Andrish's patients walked in. He had done a successful TTO when she was 15, and she came in to see me for her right knee, which was severe arthritic in the patellofemoral joint, malaligned. And the side that had the Fulkerson was pristine. It looked fantastic. And the side that never was touched because, you know, for whatever reason, had gone on to develop, you know, severe OA. And, you know, it's an eye-opening thing when you see that patient, you know, 20 years down the road, and you wonder what would have been if, you know, if she had, you know, the other side addressed.
Right.
Well, gentlemen, this is Michael. We're at pretty much at the top of the hour. So number one, you know, I want to thank you for taking the time. But kind of the takeaways for me are really kind of they're very positive. Number one, you know, conservative treatment is still, you know, very much in vogue. You know, that you do try to do some things conservatively to start, but that there are so many more options for these patients than what we had in the past. And Dr. Fulkerson, your historical you know, piece to it was very important to kind of show us like, man, it wasn't that long ago that these patients didn't have a lot of choice. So the fact a lot of people do not want to engage in these kinds of patients and procedures and problems, I think it you know, deserves a second look, and for people to you know, get involved in knowing what all these things that you can do to help these patients, because it is debilitating, obviously, when you see these patients And if you can't help them, you're going to have a friend for life. So closing comments from the three of you, and we'll wrap up.
Let me just say, Michael, I want to thank DJ Ortho. DJ Ortho has been supporting the Patellofemoral Foundation generously for quite a long time and has made a lot of education possible. And thank you, Michael, for hosting this and your friendship and just being a powerful leader in orthopedics and helping all of us. And I really want to thank, and Melanie, I want to thank you for your work. But most of all, and I want to thank Seth and Latul, your comments were wonderful. I think you guys really knocked it out of the park, at least from my perspective. So thank you for your support in making this a great educational event.
Well, I thank you, Dr. Ferguson. I am absolutely honored to share the stage with you and Seth. I've known Michael well through the traveling fellowship, and you are such the great ambassador for Don Joy Orthopedics, and they're very lucky to have you. And thank you for being a friend among many other things that you've been to me. And so thanks for having me here tonight. I agree, Dr. Ferguson, you are a giant amongst giants, and continue to inspire me. And Seth, even though I'm a few years ahead of you, you continue to inspire me. And I always say, like, I'm always one step behind Seth. And so you're a beast. So thanks a lot, everyone.
You guys are the giant.
I'm not the giant man. I'm the petite one, I think, in Michael's eyes. But I appreciate it. This has been an incredible hour. Just for the fellows and for everybody, we couldn't do any of the things that we do, traveling fellowships or courses and conferences, without the help of our industry friends and partners. And they are just that. And so we really appreciate DJO and Mike for taking the time, and Melanie. Dr. Fulkerson, I remember before I convinced you to let me go to the ANA course and teach, I cornered you in a fellows lab in up near Boston, a company lab, and you showed me how to do a quad tendon ACL autograft harvest. And this is like 20 years ago, and this is before it's in vogue. So you're on it. I'm listening carefully. I want the evolution talk. I want to know what you're doing. And, I just love Latul and I, we both are intimately involved with our fellows and our fellowships, and we care deeply, and that's contagious in the PF world, and that's why I'm involved with it. I'd say to the fellows, lastly, stay humble, continue to learn, and phone a friend early and often because we do not have all the answers. If you think you do, you are completely off the path here. So thanks, guys, and this is great.
Thank you.
Terrific. All right. Take care, everybody.
Thanks, guys. Appreciate it. Good night, everybody.